Hi, everyone. Welcome. We are re-recording the first 10 minutes of this morning's webinar because unfortunately we started the recording a bit late and we wanted to make sure those of you who were tuning in after the live viewing of the webinar would actually be able to see the whole thing. So you'll know when the splice happens because you'll see it's earlier in the day and my hair is wet. For now, I'm recording the first 10 minutes later in the day. And because I am re-recording the beginning of the webinar, I'm going to skip over some of the tech advice that we gave to people at the beginning. So welcome. Thank you for joining us. My name is Lily Farhang. I am a co-director at Human Impact Partners, and I use the she and her pronouns. And before we get started with this webinar, we want to take a couple of minutes to acknowledge and appreciate the widespread uprisings that are happening against policing across the United States. Many of you are calling in from your homes. I'm in Oakland, California, where for the past week, thousands of people have poured into the streets just 3 miles from my home. To protest unjust conditions that Black people and others across the United States face. And as I am, you're likely concerned for the well-being of those protesters and loved ones. At HIP, we feel deep grief and a collective rage for the stolen lives of people killed by police and for the brutal and ongoing injustice that Black people face in the United States. We are in awe and deep appreciation of the people and communities that are putting their lives on the line in the face of tear gas and batons and bullets, and as a global pandemic looms over all of us to say that Black lives matter. I got emotional this morning and I'm getting emotional again. I want to highlight that this policy platform that we're here to talk about today seeks to redress in small and large ways the structural violence and racism that has been perpetrated against people of color for so long, and that is especially apparent in the context of COVID. People are protesting because they're fed up with incarceration, with racist policing, with the lack of economic and housing security, and with inadequate healthcare. The struggle that people have been feeling is broad and deep, and it is now being leveraged to build power for change and a society that sees and values all of us. We thank and are indebted to the organizers and protesters, and especially the Black visionaries who are leading the way. We hope that you will consider how you can use your voice and power as individual health practitioners, as health departments, public health organizations more broadly, to take a stand against the intersecting threats of structural racism and police violence. If you need help figuring out how to do that, reach out to Human Impact Partners at any time. We are hosting an emergency conversation tomorrow at 9 a.m. with researchers and advocates, 9 a.m. Pacific, about policing as a public health issue. We'll share out details at the end of the webinar today. So with that acknowledgement, we are grateful for your presence with us, and it's so exciting to see over 500 people on the call so far, and with many more joining by the second. We are thankful to today's co-sponsors, which include the American Public Health Association, the Association of State and Territorial Health Officials, the Big Cities Health Coalition, HealthBegins, and the National Association of County and City Health Officials. We are offering closed captioning for the event, and please feel free to chat your questions throughout our time together. We will keep everyone muted, and please feel free to turn your video on so that we can see you and chat your name and where you're joining from in the bottom of the screen. So here's our plan for our time together. First, I'll share a bit of background about Human Impact Partners and our theory of change. Then Solange Gould, who's my co-director at HIP, will talk through the policy platform. Sarah Hernandez from the Office of Health Equity at the Colorado Department of Public Health and the Environment, and Jim Bloyd, Regional Health Officer at Cook County Department of Public Health in Illinois, are our speakers. Both Jim and Sarah are longtime allies of Human Impact Partners. We think of them as family. They were fellows in our Health Equity Awakened Leadership Institute, and they've both focused explicitly on working with organizers to advance policy and systems change. Thanks to Solange, Sarah, and Jim for joining us today. So just a teeny bit to introduce you to Human Impact Partners and our theory of change. I want to acknowledge that a lot of folks are probably new to Human Impact Partners because we have some new relationships through our co-sponsors for the webinar, and so this may be the first time you're meeting us. So I'd love to tell you a little bit about our organization. We're a national nonprofit, and our mission is to transform the field of public health to center equity and build collective power with social justice movements. We do that work through advocacy, through organizing, through capacity building, and through action-oriented research. And we work on a number of issue areas, including economic security, housing, immigration, and community safety. We have a long history of working with both governmental public health and community organizers. We see both sectors as instrumental in creating the conditions for health and equity in communities. And our work with governmental public health is often to build their capacity to advance health equity, often through social determinants, policy, and systems change. And our work with organizers is to often support their policy demands and advocacy that they're pushing for. And that support might look like providing research, testimony, and leveraging public health evidence. We're often bridging between those sectors and helping build relationships and trust between governmental public health and organizers. And the policy platform that we'll share with you today is an example of the bridging role that we want to play, since our aim ultimately at HIP is to have governmental public health use its moral, statutory, and administrative authority to advance very specific demands in the COVID context. Next slide, please. So just super quickly, I want to highlight our theory of change at Human Impact Partners, which is that inequities in health are really driven by an unequal distribution of power between communities, which are maintained by different systems of advantage and oppression. So things like racism, sexism, classism, and it's these power imbalances and systems of advantage and oppression that feed into inequities in housing, in economic policy, in food systems, in the environment. And so if I just want to define these terms, structural oppression are all the ways that we see hierarchies based on different dimensions of our identity, where some people experience advantage and others experience disadvantage. And power imbalances can be defined just as different abilities within groups or communities, their ability to win specific policies, to set decision-making agendas, and to change and hold public narratives. And so if we imagine these as our root drivers of health inequities and target trying to redress these unjust power imbalances and overcoming structural advantage and oppression, then we think we'll actually get the communities and the social determinants that we all want. And this theory of change is what drives the policy platform you'll learn about. We want to respond to and take action around structural injustice that manifests in the form of social determinants policy. So just my next and last slide before we start to hear, before we do a quick poll and then hear from our first speaker, Solange. So I just want to spend a minute explaining more about why partnerships between public health and community organizing are so important. So we often encourage health departments, governmental public health, to work with grassroots-based building organizations because those groups are well organized, they have an analysis, that the people who are experiencing the harms are closest to the solutions, and those who are most impacted should guide decision-making. And this aligns with our perspective and definition of equity, which is not just an outcome, but that it's a process. And organizers can help bring deep engagement skills and relationships with impacted communities that we think we can learn from and benefit from in the governmental public health side. And of course, we as public health don't have power to make change on our own. Organizers, grassroots groups, they focus on advancing social, economic, and environmental determinants of health that you care about and can be good partners in advancing a common agenda, particularly when your political context makes it hard to advance policy and systems change. And so I'm talking about building relationships with national networks like Faith in Action or the Center for Popular Democracy, or Rights of the City Alliance, which focuses on housing, United for Respect, which focuses on low-wage workers, or with more local coalitions like Deeper Than Water, which focuses on incarceration. And so these groups do systems change work around issues that we care about, and we think that partnering with them is an opportunity to actually advance our goals within public health. And there are examples from all over the country of governmental public health collaborating with these kinds of organizing groups. And the list of policy actions that Solange will talk about in a minute actually reflect the demands that we know these kinds of organizing groups are making in the context of COVID and are in response to the inequities that Black, Indigenous, and other people of color, essential workers, and others are experiencing. That's why we created the platform. We wanted to bring their organizing demands to the public health sector to imagine how we could take action. So that's our entree into this discussion and what our perspective is. So before we get started with our speakers, we're going to do a quick poll to assess participant interest in the different policy platform buckets. So Anna, if I could have you launch our poll. Thank you all for saying where you're coming from. It's awesome to see this list of almost 700 people. So Anna, I'm gonna just let you know, I'm not seeing the poll if you have launched it. And it might be because I am not.
I can see it, Lily, and we're still getting some answers. So I'm gonna give a second for folks who are choosing their answer before I share the response.
Thank you.
We got 470 of our 678 participants have responded. So I wanna, if you're trying to click, get your voice in. I feel like I'm waiting for popcorn to pop. It's like after it's still popping. All right, I'm gonna end the poll now. Thanks to all who were able to click, and I'm gonna share results.
Thanks, Anna. If you can go ahead and read them.
Can you see the poll results? Oh, Lily, okay. So what policy area are you most ready to work on? By far, the response was healthcare access, 63%, and then 10% for criminal legal system, 10% for housing security, and 16% for economic security. And if you're a participant in the chat, let us know if you can see the poll results. Hopefully Zoom is not going down on us.
Thank you. Thank you.
All right, I'm gonna stop sharing it now.
Thank you. Yeah, that would be great. And if you could just advance to the next slide for me. Wonderful. So I'm gonna turn it over to my co-director, our first speaker, Solange Gould. Take it away, Solange.
Hello, everyone, and thank you, Lily. I'm Solange Gould. I use she, her pronouns, and I'm thrilled to be the new co-director at Human Impact Partners with Lily. Before HIP, I worked at the Office of Health Equity at the California Department of Public Health, where I oversaw health equity policy and planning work. Previous to that, I worked at 3 California local health departments and community health clinics. And I want to encourage everyone to add your own name to your image on the Zoom, since we adore Anna Tejas, but we want to know who you are. And instructions are in the chat. Next slide, please. HIP's policy platform was developed to lift up the demands coming from these organizations, which came from their members who are most directly experiencing COVID-related inequities. This includes low-income tenants, low-wage and immigrant workers, currently and formerly incarcerated people, and those struggling to access healthcare and COVID testing. HIP didn't generate these ideas. They come directly from these grassroots organizations and their members who are leading the work. HIP has long-term relationships with community organizers who are already working on these social determinants when COVID erupted. And because of HIP's position as being a bridge between organizers and public health, we were asked directly by organizers to communicate these demands with and activate public health. This is a cross-sector policy platform that, if implemented, would challenge the conditions that create inequities in health outcomes. As public health, we need to do everything possible to aid in putting these policies in place to support people during the pandemic and beyond. We want to see public health and partners in health equity use our power to change the unjust systems that have perpetually harmed the health of communities across the U.S. We started with 4 health determinants that have overwhelming evidence showing their connection to health and health inequities during COVID response and recovery. And we know there are many more that are important right now, and we're updating the policy platform as the situation, solutions, and our capacity at HIP evolves. Each of the 4 issue areas has a list of policy demands, as well as specific actions that public health workers can take, tools, sample policy language, and examples of how it's being done in other jurisdictions. Some of the actions governmental public health departments and staff can do directly, and some they will need to do in a Health and All Policies partnership with other government agencies. For still other of these actions, governmental public health will need to work with non-governmental groups and community organizers, contributing health framing, research, or data to bolster these demands. By doing so, we can strengthen our relationships with organizers, which we will definitely need for the long-haul systems change work that is ahead of us. I'm not going to describe all of these policies and actions, but encourage you to go into the website and look at the various ways you can support. Next slide, please. The economic security bucket has policies to center health equity and people over profits in economic response and recovery plans. We've seen some movement in this area as the federal, state, and local bills speak to some of these demands. COVID has highlighted how important unemployment insurance and paid leave is, but many people have been excluded, and we still have a long way to go to ensure economic security for all people, no matter their immigration, employment, or health status. Public health can support the policy demands to expand unemployment, income support, paid leave, and child care programs to all workers, individuals, and families, including independent contractors and gig workers, and to formerly incarcerated and undocumented people. Next slide. The housing security bucket includes policies to ensure housing for all, protect renters and homeowners, and prevent debt accumulation during COVID. Safe, stable, and affordable housing has always been central to ensuring health. With the COVID pandemic, the long-standing issue of housing insecurity has quickly become paramount to the health of the entire nation. As a stopgap measure, federal, state, and local governments have issued partial emergency eviction and foreclosure moratoriums to prevent families and individuals from losing their homes during the COVID outbreak. These emergency measures vary greatly in form and degree of protection. While some of the moratoriums block evictions today, the vast majority still allow for widespread evictions as soon as state and federal emergency declarations expire. Therefore, we're asking public health to support policies to cancel payment requirements and suspend utility rate increases, enact a moratorium on evictions, foreclosures, and homeless encampment sweeps, turn vacant units in hotels, dorms, offices, and unoccupied homes into safe homes for those who need them, and invest in quality, stable, affordable housing for all through development of community land trusts, rent control, and other tenant protections. Next slide. The criminal legal system bucket contains policies to limit and reduce people's interactions with police, jails, prisons, and detention centers during and beyond COVID-19. We are asking public health to support policies to stop incarcerating people, decarcerate jails, prisons, and detention centers, protect incarcerated people, and divest from policing and punishment, and invest in health-affirming supports. This demand has gained a lot of momentum in the past week of protests and organizing against racist policing. And more people are demanding that our government divest funding from the harmful jails, prisons, detention centers, and policing, and invest in funding life-sustaining systems such as healthcare, affordable housing, living wages, public education, and transportation. This is going to be so important as governments are strapped for funding. Policing and incarceration, for how expensive they are not on the list of funding cuts that I have seen with the May budgets. Rather than accepting the planned cuts to our education, public health, housing, and other social welfare agencies, we must be insisting on cuts to the criminal legal system instead. Next slide. The healthcare access bucket has policies to ensure everyone has access to testing, treatment, a place for care, and protective equipment. HIP has historically not done a lot around healthcare, but we know these issues are so important for everyone right now. Organizers are asking that public health support policies to expand testing and treatment, particularly in low-income communities of color, and eliminate disparities in access, protect essential workers, and track COVID-19 data by race, ethnicity, income, occupation, and other demographics that are currently not collected. Next slide. There are so many ways that public health workers and institutions can take action, and many of the people on this call are champions who have pushed their agencies and organizations to be bolder and go further outside of risk aversion, funding constraints, and the limits of traditional public health practice. So for example, we can use our public health authority to testify on the known health impacts of these policies. We can educate ourselves on and more aggressively use our statutory authorities to push for health, protective, economic security, labor and workforce, workplace safety, housing, and criminal legal system policies, especially during an emergency. We can use our positions to convene partners in other sectors for a unified health equity in all policies response. We can always improve how we engage and center impacted communities in decision making. Next, I'm going to cover a few examples of actions that public health workers and institutions can take that we encourage you to take. Next slide, please. Public health departments have worked on paid sick leave way before coronavirus. And we're recommending that public health provides the evidence, voice, and framing and moral authority for local and state emergency paid sick leave legislation that expands on federal bills so that it covers businesses with over 500 employees, employers with less than 50 employees, and misclassified gig workers. First, assess how your jurisdiction is doing with this policy tracker from CLASP that compiles amended, expanded, or newly passed paid sick laws in response to the COVID-19 pandemic, outlining the eligibility and details of each leave policy. Next, check out this model legislation from A Better Balance, establishing a permanent right to paid sick and safe time that includes additional leave for a public health emergency. Then share this sample policy language and public health data and evidence on paid leave policies with your partner agencies that are making the sick leave policies. Next slide, please. We're asking health workers and organizations to sign on to the Public Health Awakened letter to governors and health officials, calling to keep people in their homes, provide housing for people experiencing homelessness, and protect the public's health. Specifically, this letter lifts up the demands already described in the policy platform, many of which come from our partners at the Right to the City Alliance. Another action you can take is to adopt model ordinance language for rent cancellation and eviction protections to your local jurisdictions. Check out ourhomesourhealth.org for some sample language. Next slide, please. In this moment of uprisings in response to ongoing police violence, it's important for governmental public health officials to use their authority to prevent police violence and protect people protesting for racial justice in the midst of the pandemic. Earlier this week, public health faculty at the University of Washington wrote a letter that thousands of public health professionals signed on to, naming that protests against systemic racism, which fosters the disproportionate burden of COVID-19 on Black communities and also perpetuates police violence, must be supported. Among many things, the letter advocates for local governmental public health to oppose use of tear gas, smoke, pepper spray, or any type of respiratory irritant which increases the risk for COVID-19. We are recommending that public health workers read the letter and adopt similar recommendations to protect people protesting and to oppose police violence in your own contexts. The link to the letter is in the policy platform and here on this slide. Next slide, please. We know that many public health departments are hiring contact tracers, and we're asking that you look at and sign on to these community-based workforce principles developed by one of our co-sponsors for this webinar, HealthBegins and their partners, and help agencies adopt the principles as they expand their contact tracing workforce to ensure that response efforts are appropriately embedded in disproportionately impacted and vulnerable communities. Next slide, please. Thank you so much for joining us to learn about the Health Equity Policy Platform today. I hope that you'll go into the website and take a look at the entire list of policies and actions and decide which of them you can move forward with the power and authority you have as a public health worker or health partner. Thank you so much.
Thank you so much, Solange, for presenting on HIP's policy platform. I'm going to ask one clarifying question that came in. Around how Human Impact Partners decided to focus on these 4 buckets specifically, and whether or not we imagine and want to include climate justice and environmental justice within the framework, particularly in light of the evidence linking long-term kind of pollution impacts to COVID and other health issues.
Yeah, I'm very happy to hear that question. As I said earlier, these are the 4 policy buckets that our organizing partners most urgently were working on when the pandemic erupted, and that we very quickly were able to pull together the policy platform around. We know that there are many others that you all are working on. I know that there are people here working on education, climate justice, transportation and mobility, equity, et cetera. And so for those of us who have sent us input, we are taking input and are interested in hearing about other improvements. In particularly around climate justice, I appreciate that question. Just like COVID, the climate crisis is a health inequity and a social injustice threat multiplier. And we know that all of the work that we can do right now to strengthen community resilience around COVID is also going to strengthen our resilience around climate changes. They are intertwined with the systemic racism, with the late-stage capitalism, with the numerous health inequities that we're experiencing in our communities that are making COVID worse. And so I can't promise that we will have a climate justice bucket, but I do believe strongly that all of the things that we're doing through this work as public health to strengthen community health will also strengthen us for climate change health inequities.
Thank you, Solange. I appreciate that. So there are some questions coming into the chat. Our chat moderators are collating them, and we will have time in about 10 to 15 minutes to answer some of those questions. So I'm gonna turn it over now to Sarah Hernandez from Colorado to share a bit about their process of developing an equity response team at the state. And just a quick reminder, go ahead and chat any questions that you might have for Sarah while she's talking. Take it away, Sarah.
Thank you so much, Lily, and thanks for the invite to be with you all today. Thanks everyone on the line. I know that everyone is very pressed for time these days, and I appreciate you all coming together for today's webinar. I am the Deputy Director at the Colorado Office of Health Equity, which is located within the Department of Public Health and Environment. And also I use she, her pronouns. And as Lily mentioned, we pulled together a COVID health equity response team. And so I'm here to talk to you a little bit more about that today. If we could go ahead and go to the next slide, please. So back in April, our Governor Jared Polis, tasked the Office of Health Equity with creating a team to respond to the racial inequities that we were seeing related to COVID. And so we put together a team that is comprised of community organizers and grassroots leaders of color. In the selection process, we also considered intersectionality, meaning we looked at other identities that folks brought to the table. So specifically geography and especially people living in rural areas, people living with a disability, and people who were part of the LGBTQ community. But we have a team that is almost 100% comprised of people of color on this group. If we could go to the next slide, please. And so at this point, the group has pulled together their recommendations based on 4 main areas, and that's what you're seeing on the slide here. And the first 3 directly relate to HIP's policy platform of specifically economic security, housing security, and healthcare access. And so it's a combination of items related to executive order types of actions, as well as public health orders and supporting legislation. As of today, the recommendations are not public, but I'm hoping that within the next week or so, those will be public and they will be on the website. You see the website on the slide here, and that's where you will be able to access them in the near future. And I just want to really lift up what Lily was saying around centering the work of the community organizers who are part of this group, and we really centered them in all of the decision making. So they are the driving force behind this group, and we really see our role in government as just being here to facilitate the process. And so we are doing whatever we can to bolster and support the voices who are on this group, especially because they are day in, day out living the impacts not only of COVID, but of these long-term systemic issues. And so that is one reason why the group is also very much focused on not just coming together, solving issues around COVID, as they relate to testing, for example, and messages and communication and that kind of thing, but actually looking at putting some policies in place that will have long-term impacts, because we know from looking at previous crises and emergencies that communities of color are the ones who bear the brunt of when we're in these types of situations. Thinking about, Hurricane Katrina or the 2008 recession. And so the group is very much focused on recovery efforts, and particularly with COVID, because, we might be seeing a second wave or a third wave. We want to be sure that communities of color are well poised to be incorporated into response efforts and, won't be bearing the brunt of everything that's going on with this pandemic in the long term. And with that, I'm going to go ahead and wrap it up as just kind of to give you a high level overview of what we're doing with the equity response team. And I know that we'll have some time for questions as well. So thank you.
Thanks so much, Sarah. There are a number of questions coming in already for you. And maybe I'll just say them so you can think a little bit about your response when we open it up to the general discussion. So folks are asking whether any recommended actions from the equity response team address telemedicine. There's questions around planned follow-up from the equity response team, how you're planning to monitor implementation of the recommendations. And then I think people are curious about the structure of the group and how it came together. So maybe just jot those down and I'll come back to you after Jim to share out about that. So with that, I would love to turn it over to Jim Bloyd from Cook County. And a reminder that for specific questions for Jim, go ahead and drop them into the chat. Take it away, Jim.
Lily, thank you very much. Can you hear me okay?
Yeah, you're coming across super, super good.
Great. Good morning. Well, thank you so much, Lily and Solange and Sarah. It's good to be with you. Thank you for having me. I want to acknowledge that this country was founded on the enslavement of Black people. I speak to you from metropolitan Chicago, which is on land stolen from the Potawatomi, Miami, Ho-Chunk, and other nations under the doctrine of discovery. I'm Jim Bloyd. I've worked at county public health departments for over 20 years, first in Los Angeles, and then in Lake County, Illinois, and then here in Cook County. So I'm going to be speaking specifically about what our agency is gaining before and also now by working with organizers to build people power for health equity. In 2015, the Cook County Department of Public Health prioritized health equity, and we specifically named structural racism as a root cause of health inequities. Next slide, please. Thank you. As Sarah pointed out, that communities of color bear the brunt of crises. That is happening right now under the COVID-19 crisis. The Chicago Metropolitan Agency for Planning, or CMAP, research shows that essential workers, particularly people of color, and those who live in low-income communities in our jurisdiction of suburban Cook County outside the city of Chicago, they play critical roles in providing health care and keeping transportation, food supply, and other essential systems going during the COVID crisis. So the CMAP reports that these occupational patterns, we see occupational patterns of segregation by race and place in suburban Cook County. So these are the very communities during the COVID crisis that the Cook County Department of Public Health is better able to serve because of the work with the power building organizations you see above here on this slide. So first, the Cook County Department of Public Health is working with the Illinois Attorney General to enforce COVID workplace rules for workplace safety. So our partner, Arise Chicago, Adam Cater, the organizer, hears directly from members of Arise Chicago, which allows CCDPH to more effectively enforce COVID workplace safety requirements of social distancing, PPE availability, and sanitation. And Arise has accepted an invitation and will be speaking on this in our Thursday weekly COVID updates. Secondly, CCDPH commitment to Cook County, one of the logos here, the Collaborative for Health Equity Cook County, has allowed the health department to participate in efforts to push for more transparency and more protection for immigrant health, for adults and children and minors in detention centers who are facing mass deportation threats by ICE and where ICE has locked people up. Some of these facilities are also located in our jurisdiction, but it also overlaps into a statewide issue. The health department began intentionally reaching out to organizers in the Chicago office of Restaurant Opportunity Center United, or ROC Chicago, and I helped develop that partnership a while ago by creating fact sheets with public health data that were useful to ROC Chicago. The work with ROC led to more relationships with organizers working in our jurisdiction. In Calumet City, for instance, a southern suburb of Chicago, we worked with Centro de Trabajadores Unidos, United Workers Center, and Southsiders Organized for Unity and Liberation, or SOUL, who are collaborating on passing an ordinance to raise the minimum wage to $15 per hour and demanding that tipped workers be paid the same minimum wage rather than a sub-minimum, a substandard wage. There was a historic win in Calumet City in which voters overwhelmingly by 82% approved an advisory statement on the ballot supporting these policies, but then later a campaign to pass an ordinance putting this into law faced more opposition. And the health department met with municipal elected officials together with CTU and SOL organizers to describe the benefits of raising these wages and supporting one fair wage. And at this point, the Cook County ordinance, Cook County as a whole, had passed an ordinance raising the minimum wage. And I have to note that that ordinance did throw tipped workers under the bus and left the sub-minimum wage in place, which was very disappointing. But what I'd like to point out, though, is that many suburbs were even opting out of that ordinance. And so one of the things we did is we generated a sign-on letter, and many hundreds of people signed on to that. And there was an effort to put that sign-on letter into an op-ed, which we did, and that was in the Sun-Times, urging suburbs to opt back in. Cook County Health Department has had multiple staff, including our co-directors, Dr. Rachel Rubin and Dr. Kiran Joshi, meet with organizers of low-wage and immigrant workers. So Arise, for instance, I mentioned they've worked with individual suburbs. Arise has worked with individual suburbs to advocate opting back in to the county ordinance, raising the minimum wage. And Dr. Kiran Joshi provided testimony at some of those public discussions with elected officials at board meetings, urging them to raise wages as a public health priority. So I just want to note that these relationships with organizers, they start out, they grow. They can start with a phone call. I remember sitting down with Tanya Watkins of Soul Chicago to learn from her about what her work was and how our agendas could overlap. And similarly, we've done that with other organizers. I had a conversation with Arise Chicago's organizer, Adam Cater, and he talked about the work that they're doing. And that has led to some other benefits during this crisis of COVID-19, where because of that trust and relationship in the past, we were able to turn around a grant, a proposal for funding in 2 or 3 days, and that would not have happened otherwise. So I see you're advancing the slides. This is a referral to the Chicago Sun-Times op-ed piece, and I'll look forward to answering more questions later. I do have a number of resources on the final slide, and I'd be happy to send those to people who are interested. Thank you.
All right, thank you, Jim. So we've got about 12, 13 minutes that we'll use to respond, Jim, Sarah, and Solange, to some of the questions that have come in. So one question that's been asked, Sarah, I'm going to come to you in a second to maybe just reflect on some of the questions I posed earlier. One question that's been asked several times is, how has language access been addressed? And I'm going to be more specific in your COVID response. So I don't know, Sarah and Jim, if you would like to say anything about that, or anything more broadly related to language access. Sarah, why don't I go with you first, if that's okay?
Sure. Thanks, Lily. Yeah, so here in Colorado, there has been a significant amount of efforts going toward language access. So specifically, any materials that are coming out of the official COVID response, so that could be from the health department or from what we call the Joint Information Center, which is multiple state agencies involved in the COVID effort. Those materials are translated into 5 languages. So what we did is we looked at the demographics of Colorado, and based on that, we found the top 5 most commonly spoken languages in the state, and so materials are translated. Similarly, materials on the website are translated into those 5 languages. And that being said, I'll just acknowledge that this is an ongoing challenge for us. And we are lifting up the need to hire contact tracers who are multilingual, as well as creating materials that we're trying to go in a direction where our materials are less and less words and leaning more toward infographics and videos and that kind of thing, so that hopefully it's cutting down even on literacy barriers as well. Jim, I'll let you weigh in as well.
Sure, thanks, Sarah. Yeah, I agree with your opening sort of general assessment that more needs to be done. I think really language access barriers are really an evidence of kind of a structural barrier. It's oppressive, it's structural racism. It discriminates against people based on national origin. I know our agency is working very, very hard. I would say we need to do better. I know that, for instance, up until now, most of our webpage has not been translated into Spanish or other languages, for instance, but I'm happy to report that a large number of our content is going to be available in Spanish in the text in a few days, a week or so. I also know that our hotline, which has been operated, and I worked on it for 7 days as a caller myself, and then was a supervisor for a couple of weeks, that we struggled with kind of an unwieldy system of providing remote interpretation, interpreters in real time. So it's something that I think we have to pay attention to, and I think we'd recognize that our health departments also are in a context of structural racism, and so all of us inside of government have to struggle with this issue.
Thank you. Thanks. Sarah, I'm going to turn it back to you just to share for a quick minute, if you don't mind, a little bit about the equity response team, just like a teeny bit about the structure of the group, like what's the planned follow-up going to be, kind of how much it's connected or embedded with others working on COVID response.
Sure. So the structure of the group is that we meet on a weekly basis, and the Office of Health Equity is the one kind of pulling everyone together, working on administrative tasks. And we really are honoring the time of our community leaders who sit on this group. And so when we asked them to be a part of this group, we committed to doing kind of all of the in-between meeting work and background research and that kind of thing. And so we do that in between meetings. And as well as kind of having conversations with folks who are in a decision-making role. So to that end, we sit on the incident command team in various forms and iterations, and are really working now to embed equity in the state emergency operations response. And that is, you know, that's affecting a lot of different things. And so there's a lot of exciting conversations there. As far as implementation and success, the members of this group really want to be able to count wins, right? So they don't want just kind of lip service. They don't want to be a tokenized group. And so the plan is to keep meeting until they feel like, you know, their recommendations have been addressed. And so it was intended to be a short-term group, and we will leave it up to the group member to determine kind of when the timing is right to transfer, I should say to transfer format to something different. But there has been interest already in keeping this in some kind of permanent structure. And so we'll be having those conversations over the next few months and you know, even longer. But one idea that has been lifted up is actually having some kind of permanent network of community liaisons in place, and they would be compensated for their time as well. And again, that relates to the second wave and third wave that may be coming with COVID as well. So we want to make sure that we have those systems and those meaningful partnerships in place for that. And I'll stop there, Lily. I know that we're short on time.
No, I appreciate that's great. So let's see, there's a question in the chat. So their questions are coming in fast and furious. One thing I would recommend if folks are interested, you can scroll up and down and actually answer other folks' questions. I really appreciate that some of the participants are answering and sharing resources in response to other folks' questions. We're not going to get to everything, and our hope is to send out some responses to the questions that rise to the top. So one that came in, and I'm curious for all of your take on this, was around, are there, you know, a lot of what we're talking about is shifting public policy to reduce kind of pre-COVID exposures and policies to respond to new exposures, if I can use my public health lingo, that have resulted since COVID, right? So like eviction, moratoriums on eviction are something people fought for prior to COVID, but the need for it has like really lifted up and has been lifted up. Paid sick days, again, policy need that existed pre, but COVID is shining a light post. So one question that came through is whether there are legal or other constraints for public health officers, nonprofits, funders, private businesses to endorse policy change, legislation, organizing, and advocacy efforts. And I think I just want to take a quick second to answer that question, which is nonprofit organizations. So that's a long list, right? Public health officers, nonprofits, funders, like each of those is a different institution. So number one, many of the calls to action that we shared are actually for individuals. So there's nothing that prevents you as an individual from being able to sign on to some of these as an individual human being. Some of them are asking for organizational endorsements, and they're more around showing support for platforms and ideas. And so you're not actually lobbying for specific changes to decision makers or doing grassroots lobbying. What you're actually doing is saying we stand by these kinds of demands. The other thing is nonprofits can lobby. I mean, we are actually allowed to lobby. And so understanding what your ability is to lobby is important. And then there's all kinds of advocacy that public health people can do that Solange really pointed to, which is not about legal or, you know, other kinds of constraints, like that don't present legal constraints, but are actually about using the data and evidence and information and moral authority that we actually have to show support for some of the demands in the policy platform, like paid sick days or, you know, an eviction moratorium. So I wanted to speak to that specifically. I don't know if any of the speakers just have anything that they feel like they want to add. If you want to jump in, go ahead. Otherwise, I'll move on to the next question.
Yeah, let me just jump in real quick on Lily. I think that question is really crucial for public health. I would say public health leadership at the state and local level, at all levels of government, we have an ethical duty and a responsibility to educate elected officials about the kinds of policies that tackle root causes, that tackle structural racism and the other kinds of oppression that have led to the pre-COVID inequities and to the current ones. We don't want to go back to the unacceptable past. We don't want to go back to that normal. We want a new society, and public health as a duty to educate policymakers and to, we can't be neutral. So those protesters on the street, I thank them, and they're our allies. And so it's a job of public health to support policies that end structural racism and other kinds of oppression.
Oh, go ahead, Solange.
Thank you, Jim. That was very well said. I agree. This is not a time for public health to limit what we do. We are always told to stay in our lane. We often see our leaders who step out of their lane treated poorly. And I think we're in a situation now where we have an unusual amount of recognition and authority. Let's face it, most people didn't know what public health was before COVID hit. And so I really agree with Jim. We should be using that authority, not be risk averse. I recommend going to ChangeLab that has developed a number of resources on what public health authority is right now. And then I just shared in the chat an excellent resource by Boulder Advocacy that describes the bounds of advocacy. And people think of policy as big P policy, but in public health, we do all kinds of policy, including big P and little p policy every day. That means just the way that we operate, the things that we speak about, the data we produce, who we partner with, all of that is policy work as well, and everyone can do that.
Thank you so much. Let's see, a question came through. I just want to loop back to the sort of opening acknowledgement we did of the uprisings and protests. There was a question that came in, is there a way to protest in a way that prevents COVID-19? And I do want to acknowledge that the letter from the University of Washington that was posted earlier is all about how to protest in a way that prevents COVID-19. It involves both preventing police from escalating things via tear gas and like respiratory irritants, and stopping arrests, which put people in confined spaces where COVID is more likely to spread. and ensuring people have masks and hand sanitizer at protests. So I do encourage you to check that resource out if you're interested. I also want to highlight that there have been a number of questions and responses that have come in related to how to talk about racism as a public health issue, or and actually address racism using our public health authority. A few resources were shared from the American Public Health Association that I encourage folks to check out. And actually, I will just admit that every one of our co-sponsors, the Big Cities Health Coalition, ASTHO, NACCHO, HealthBegins, has materials and resources, human impact partners, on racism as a public health issue, and I would encourage you to check those out. So I'm gonna actually wind us down in our last couple of minutes. I'm amazed that there's still close to 600 people here on this call. Anna, if I could just ask you to advance to the next slide, please. So just again, thank you, Solange, Jim, and Sarah for joining us today. And it makes me, I know it's impossible to do these things for longer than an hour. I do wish we had more time because there's so many questions that folks asked. And it was great to hear both the work that you're doing and kind of your responses to people's off-the-cuff questions. So thank you for that. I want to again thank all the co-sponsors, ASTHO, APHA, Big Cities Health Coalition, HealthBegins, NACCHO. It was wonderful to have you as partners in this, and we look forward to doing that more. We will, as was stated in the chat, follow up with an email that has the recording and other follow-ups. Go ahead and feel free to email any of us with feedback or comments and ideas. And the last plug that I'll just do, which I started with at the beginning, next slide, Anna, please, is to feel free to join us tomorrow, Friday, June 5th, at 9 a.m. Pacific time for an emergency conversation with researchers and advocates about policing and how it is a public health issue that we should be thinking about and addressing head on as a field. So thank you all so very much. And we look forward to hearing from you in the future.
Thank you very much.